like a PDF via an announcement that we'll use at the very end. You don't necessarily have to have that, but it's easier than you writing those things down. So either way is fine. Yeah, if you didn't see that yet, you can grab that. Otherwise, here we go. So talking about diabetes and cardiovascular disease, we're going to start with the diabetes portion. Let's go ahead and chat about this with your team and send in what you think the answer is here. Most common in the US. All right, go ahead and send that in if you haven't yet. Got everybody? All right. Okay. So yeah, most of you are saying B, type 2 diabetes, which is absolutely the correct answer. We'll see in a sec, 95% of diabetics in the US are type 2 diabetics. Okay. One quick question for you. What's the one thing that ties these four diseases together? Ask your teammates that. Why are these all called diabetes? What's the one thing what one symptom in common with all four of these types? Ask each other real quick. Yeah. All right, who knows the answer? Who's got it? Raise your hand. Ava, what do you got? You pee a lot. Yeah, that's right. Yeah, you pee a lot. That is the one common thread with all these. These three involve blood sugar, right? High blood sugar. This one doesn't though, right? That one just has to do with ADH. But the thing that ties that one in is common that everybody pees a lot. Okay. So let's talk about the two diseases that we'll talk about. So just some statistics here. Cardiovascular disease is still the #1 cause of death in the US. Last round of statistics showed about 690,000 deaths in the US in 2020. And so in 2020, this resulted in one cardiovascular disease death every 45 seconds in our country. Right? And so that's about the same place we're at now, which means, in the course of a 50-minute class period, got that many, at least over 100 people dying of cardiovascular disease during the course of this class. Okay. In the latest diabetes statistics show about 11% of the population has type 2 diabetes, which is 37 million people. But more staggering than that is pre-diabetes, which is 38% of the US population. Okay, so 96 million people. And then $1 in every $7 in healthcare is spent on diabetes treatment, amounting to about $800 million per day in healthcare costs related to diabetes. So these two diseases are just massive problems for sure. And so we'll be talking about them. When it comes to cardiovascular disease, if we look in the deaths that all fall under the category of cardiovascular disease, what are the most common causes of death within that? And most of those, or at least over half of those, are heart attacks, right? Coronary artery disease is the #1 cause of death within that. And then you've got a good chunk with stroke, some with heart failure, hypertension, and then other. Okay, but heart attack is the big one. Okay, or myocardial infarction. Okay, questions about any of that so far? Okay, so let's dive into the physiology of diabetes a bit here first. So we'll start with the pancreas, right? We've talked about the exocrine portion of the pancreas. We were just talking about that, right? With all the pancreatic juice and all those enzymes released, right? So that's the acini cells, right? And those acini cells release pancreatic juice, which includes bicarbonate, right? A lot of bicarbonate, and then a bunch of enzymes to help us digest the food that we eat. Okay, that's the exocrine portion. But then the endocrine portion is not connected to the digestive system is connected to the blood, right? So it's going to release things into the blood instead. These cells are called the islets of Langerhans cells. Okay. And so within those, we have alpha cells and beta cells. The alpha cells, it's about 20% of those cells. Bless you. And they produce and release glucagon. Okay. The stimulus for the release of glucagon is when we have low blood sugar. Okay. Its actions include stimulating the liver to break down glycogen and then release that into the blood. Okay, so glucagon goes to the liver, tells the liver we got low blood sugar. The liver breaks down the stored form of carbohydrate there, turns it into glucose, and puts it into the blood. So raise our blood sugar back up. Beta cells, which are 75% of the cells in the islets of Langerhans, um, they release insulin. Okay, and then the stimulus for that is the opposite. When we have high blood sugar, we release insulin. That allows our glucose to come into our cells. Okay, it also stimulates the liver to produce glycogen, to take the glucose in our blood, pull it into the liver, and turn it into glycogen so we got stored carbohydrates available for us. Okay, so that's just kind of a quick overview. Go ahead and run through this little flow chart here. All right, so we'll start over here. When blood sugar goes up, all right, what does the pancreas release? What are its actions? What's the final effect, right? When the blood sugar goes down, we go this way. So yeah, go ahead and we can just walk through it together. Actually, let's just do that. So when we have an increased blood sugar, okay, which one are we releasing, insulin or glucagon? Insulin, got it. Okay, there's our insulin. Insulin's going to cause glycogen formation in the liver. Okay, so we're pulling glucose out of the blood, turning it into glycogen, and it's also going to cause our cells to pull glucose in. Right? So glucose uptake in our cells. And then the end result of that would be that our blood sugar goes back down. Okay, so that's that one. And then if our blood sugar drops too low, right, then that's the stimulus there. We're going to see the release of glucagon now. Okay, and glucagon is going to cause the liver to break down the glycogen that it has and release that as glucose into the blood and raise our blood sugar back up. Okay, so this is how it all works when it's working normally. Questions on this at all? Okay, looks like guys are about done. Okay, so then let's talk about diabetes. Okay, so diabetes mellitus is broken up into type 1, type 2, and gestational diabetes. Okay, so type 1 diabetes, the cause is autoimmune, meaning that our immune system attacks our own pancreas. Okay, and the main pathology is that our immune system destroys those beta cells, those ones that make and release insulin. Okay, so then the result of this is we don't produce insulin, we can't release it, so we have a really hard time getting blood glucose into our cells, right? This is only of all the diabetics in the US, this only amounts to about 5% of those. And this used to be called juvenile diabetes because of the onset that typically happens when someone's a kid. It can happen into the 20s. There are some cases of that, but not too much later than that. And then we got type 2 diabetes, formerly known as adult onset because it used to only occur in adults, but now we have cases of kids getting type 2 diabetes, and that's why we don't use juvenile and adult onset anymore. The pathology here, the primary pathology is insulin resistance. Okay, we'll talk in more detail in a second about the different pieces of the pathophysiology, but the primary one is that our body isn't responding to insulin like it's supposed to. Okay. And so then the result of that is you need to release more insulin to get the same amount of glucose into your cells, and eventually you start not being able to produce insulin to long-term type 2 diabetics. But this is 95% of the diabetics in the US. Okay, and then gestational diabetes is a form of type 2 diabetes, but it just comes on during pregnancy, and then it goes away after delivery, typically. If it's not managed well, then it does increase the risk for the baby eventually to have type 2 diabetes and for the baby to have obesity and some other things. But it's kind of normal for the mom to have a little bit of insulin resistance during pregnancy because the body's trying to save some glucose for the kid, right? And so it's normal for the mom cells to kind of block a little bit of that action. So there's glucose available for the kids, but this is kind of like a overshoot in that, and gets more intense insulin resistance, which then leads to higher blood sugar, and kind of leads to like over nutrition in the fetus. So somewhere between 2 and 10% of US pregnancies has this. So questions on that at all? Okay, so a little bit more detail into type 1 diabetes. The body can't get glucose into the cells, and so the cells start starving, right? We can't get our primary fuel source, right? So the body starts turning to protein instead, and we start breaking down skeletal muscle. That's our biggest source of protein that's just kind of there. None of it is there as a storage site. It's all there doing something, right? It's all functional, but we still break it down, right? We break it down, and so we start losing weight. Um, Part of that weight is muscle mass that's lost. And then we start turning to fat, of course, as well. And one of the fats that we can make in starvation mode in our body are called ketone bodies. And so when your body is starving, the liver can form these special fats called ketone bodies. And they're a great source of fuel for very important organs like the brain, the heart, and the liver. Okay. But the problem is they're very acidic. And so when they're very acidic, this drops our pH. And this is one of the causes of metabolic acidosis. Okay, so when people say they're on the keto diet, right, this is kind of what they're trying to refer to, is they're trying to put themselves into ketosis, right? And ketosis means that you're starving yourself and your body's making ketones, right? But it is a pretty dangerous situation, actually, if they're truly on a keto diet, which most people aren't, because it's under 5 grams of carbs per day to cause this, which is not, it's almost impossible unless you just completely avoid carbs. But it can actually be a dangerous thing where you cause damage to your body if you're truly on a ketone diet. But it's actually used as a treatment for certain things, like seizure disorders can be treated pretty well with yeah, ketone producing diets and other things, but those patients need to be medically supervised while they're on that kind of diet. So most people that say they're on a keto diet aren't really on a keto diet, but yeah. Yeah, 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 it would, some of that for sure. You get some, and you can also get bone wasting as well because of the low pH. Not because of thing, but because of the low pH, that kind of starts, yeah, leaching your calcium phosphate salts in your bone too. But yeah, so it's not really something to mess around with, but yeah. So yeah, the other big factor here is dehydration, right? We talked about this already when we talked about the kidneys, that the kidneys are responsible for reabsorbing glucose, right? Most of that happens in the proximal tubule, right? And but there's a certain capacity to that, right? So when there's just way too much glucose in the blood, that goes into the filtrate. There's just more than the proximal tubule can get back. So some of it stays in the filtrate, but that creates a lot of osmotic pressure in the filtrate, right? So that pulls more water with it. And so there's just lots and lots of urination, right? And so that's the big thing. So that's the polyuria piece. And then also that makes people very thirsty. So polydipsia is the medical term for that. And so then in type 1 diabetics and in type 2 diabetics, people can go into a diabetic coma. And it's not always the same cause. People can go into a diabetic coma because of the hyperventilation that happens with metabolic acidosis, right? Your pH is dropping too low, right? The way that your body responded to that was to get rid of some hydrogen ions in your kidneys, but also to breathe more, right? Increase ventilation. But that hyperventilation can possibly make you pass out. Um, Also, you can go into a coma with very low blood sugar, and that's a super dangerous one that can cause brain damage. Um, and then also just severe dehydration due to hyperglycemia. So when you really have high blood sugar, that can make you urinate so much that you get so dehydrated that you pass out. So diabetic coma doesn't just necessarily mean one thing, like low blood sugar. It can be caused by multiple things. Questions on those at all? Okay, so the treatment for type 1 diabetes is extensive for sure, but it's very treatable. And when I first started teaching this class, which was 13 years ago now, so that was 2013. This system of an artificial pancreas was not approved by the FDA yet, and so it was kind of like a dream. Like at some days there'll be an artificial pancreas that we can use, and but now it's approved. So pretty much the idea is you always need insulin injections of some sort when you're type 1 diabetic because your body's not producing insulin, so you give yourself the insulin. But with an artificial pancreas, you have two devices that communicate with each other. One of those devices is called a CGM, continuous glucose monitor. And this is just inserted in the skin, usually lasts, depending on which type it is, lasts for a week or a couple weeks. And that's constantly measuring your blood sugar. And then that device communicates with the second device, which is the insulin pump. And so the insulin pump's also inserted in your skin. That one needs to be replaced every few days, typically. Um, and so the CGM is telling the insulin pump what the blood sugar is, right? And so when the blood sugar starts going too high, the insulin pump releases some more insulin to drop your blood sugar down. When it's dropping too low, the insulin pump stops releasing insulin. Okay. When you go to eat a meal, you type in how many grams of carbohydrates you're going to eat, and then the pump sends in the right amount of insulin based on that. So yeah.
Um, how did they get into the blood sugar? Was it like you get into like skin?
Yeah, it actually measures it in the interstitial space. And oh, how's it get in? Yeah, same idea. It's being inserted into the interstitial space, so it needs to be in just some tissue that has some fat, and it gets in. There's a little insertion device that goes in there, and then the needle comes out, and a little tube stays in there, a little like catheter type tube, and so the insulin just kind of gets pumped through that, and it goes into that interstitial space, which then eventually can get right into your blood from there. So yeah. My son has type 1 diabetes and he was diagnosed when he was 10. He's 17 now. But yeah, pretty crazy. He had most of these symptoms that we're talking about here. He was before he got diagnosed, he was hyperventilating for sure. He was starting to get blurry vision because he had so much extra glucose in his blood. It was like it was starting to bring in extra like fluid into his eyes, which can do that. He had lost a ton of weight. He had lost like 20 pounds. He was like went from like 91 pounds to like 70 pounds. And yeah, and I just remember like put my arm around him and like, oh, he's like a skeleton. Like where did all the muscle mass go? And we noticed he was peeing a ton. Um, but every time we would clean the toilet and then it would like the next day it would be full of mold again. We're like, why is the toilet get full of mold like every day? It was really because there was a bunch of sugar in it, right? And the mold was like loving the sugar. But all of these things kind of, my wife's a nurse practitioner and I obviously teach his stuff. And we still didn't even really catch it till he was like, it had been a long time. So it felt pretty dumb at the end, but yeah, so but yeah, it's an overwhelming disease in a lot of ways because there's so many things to manage and bring home and work with, but it's very treatable once you kind of figure all that out. So um, yeah, questions or comments on any of that? Okay. All right, so type 2 diabetes is again more of there's definitely a mix of genetics and behavior factors that lead to this. The estimates for how much of a genetic component is involved in this kind of have a wide range, but it's probably somewhere at least a third of it is genetic, maybe up to 60%. Um, and physical inactivity and obesity are highly correlated with type 2 diabetes as well. And so the progression of it goes that the cellular response to insulin becomes impaired. Okay, so we've got these little insulin receptors on our cells, right? Insulin's supposed to come, bind to that, cause this whole chain of events to happen inside the cell. And then one of the effects of that would be these little glucose transporters called GLUT4 are supposed to go to the surface of the cell based on the insulin binding to it, right? When GLUT4 goes to the surface of the cell, that forms a little gate for the insulin to get in. Okay. And so with type 2 diabetes, this response becomes impaired, meaning that it takes more insulin binding to the cell to get the same amount of GLUT4 to come to the surface. And this leads to, that is what's called insulin resistance, right? So more insulin to get the same amount of glucose out of the blood. And it gets worse and worse and worse. And eventually, years after the onset of this problem, we finally get an increase in blood glucose, right? So pretty much we have high blood insulin levels for a long time during this progression. But the increase in insulin release is kind of hiding the fact that there's a problem here. And so you never really see the high blood sugar until years down the road. And then the blood sugar starts to elevate. So that's like the first part of it. But during this time, since the pancreatic beta cells are having to work so much harder to keep up with the insulin resistance, by the time diabetes is diagnosed, there's only about 40% of our beta cells left at that point. So it's not just that we have insulin resistance, but it's that the beta cells are also dysfunctioning at that point too, because they've kind of been overworked and other reasons as well. So we get lower insulin production and release too. So with type 2 diabetes, it's diagnosed by either fasting glucose levels or hemoglobin A1C. So fasting glucose of 126 or greater is diabetes. Pre-diabetes, that one that was 38% of our country, that would be fasting glucose of 100 or more. Okay, but below 126. And then remember, hemoglobin A1C is like our average blood sugar for a couple months. So that can also be used as the diagnostic criteria too, either above 6.5 for diabetes or between 6 and 6.5 for pre-diabetes. So the consequences here include number one, cardiovascular disease. Okay. So 2 to 4 times more likely to have a heart attack or a stroke if you have type 2 diabetes. So massive increase in cardiovascular disease with diabetics. Kidney failure, okay, too much glucose to deal with. Kidney cells get overworked and kidney damage ensues. And vision problems, okay, so blindness, cataracts, mostly due to blood vessel damage that occurs feeding our eyeballs. Um, yeah, so those are just a few of the consequences. The other one that's not on here that should be is Alzheimer's disease. Alzheimer's disease is tightly linked with type 2 diabetes. It's actually called in the literature called type 3 diabetes, Alzheimer's disease, because it's so closely linked to it. The extra glucose in the blood damages our neurons directly and causes Alzheimer's disease. So, yeah. So treatments, diet modification, exercise, weight loss, drugs that help you to sensitize your body to insulin, like metformin. But then eventually, type 2 diabetics, when their pancreas completely wears out in later stages, they also need insulin injections, just like type 1 diabetics. So, yeah, questions on that? Okay. So to look at the kind of big picture of type 2 diabetes pathophysiology, we've got really three primary components. Okay, number one is the one we've talked about most, which is decreased insulin signaling. That would be the insulin resistance part. Okay. This is associated mostly with our skeletal muscle. Our skeletal muscle intakes about 80 to 85% of our glucose. And so if we have a problem getting glucose out of the blood, then we have a problem with our skeletal muscle. And that's associated with mitochondria that aren't working quite right and lipid accumulation in our muscle. So that's the first part, okay? And then we just talked about how we also start to have damage to our beta cells, right? The pancreas has a harder time releasing insulin, which is typically you might be thinking that's just type 1 diabetes, but it's also type 2 diabetes as well. And then third is this one. So that's the liver. Okay, so the liver there, that's a little picture of what the liver is supposed to look like. This HGP stands for hepatic glucose production. Yeah, hepatic glucose production is what the HGP is, okay? And we have a certain types of fat build up in our body that's more dangerous than others, and one of those types is called visceral fat. So when we have fat that's built up around our organs instead of just like our subcutaneous fat under our skin, that's the one that's really highly associated with cardiovascular disease and diabetes. And we talked about a little bit before with the liver getting fat buildup in it, right? That visceral fat that's close to our liver releases fat, releases it, and it goes right into the liver. That eventually builds up liver fat, which eventually causes decreased sensitivity of the liver to insulin. Okay, so the job of the liver is for blood glucose is when we're fasting, when we're not eating any food, we still need blood glucose, right? And so we haven't eaten for 8 hours when you sleep, the liver senses that and releases glucose to keep keep your blood sugar stable. But then when you eat a meal, we don't need our liver to release insulin or release glucose because we just ate a meal. So that the insulin release that comes with eating a meal tells our liver to stop releasing glucose. Okay, but in type 2 diabetics, that mechanism is broken, and they just keep dumping keep dumping glucose into the blood from the liver. And so that's what this one's referring to. So those are kind of the three key pieces of the pathophysiology of type 2 diabetes. Questions on that? Yeah, Kieran?
Where it's like INS.
Insulin, yeah. Decrease insulin sensitivity. So same thing we talked about over on the skeletal muscle side, but just also in the liver. Yeah. Other questions? Okay, so that's a little bit about diabetes. We're going to switch gears and talk about the physiology and pathophysiology of cardiovascular disease a little bit. Okay, so cardiovascular disease, again, the thing that leads to heart attacks and strokes, the number one cause of death in our country. The primary underlying pathology is called atherosclerosis. Okay, this means a hardening of our arteries, which involves plaque buildup. And then eventually the thing that leads to a heart attack or stroke is a blood clot. Okay, so factors related to that would be genetics, obesity, saturated fat diet, physical inactivity, and definitely diabetes. Okay, and the first sign of this that's connected to all of this is related to the cells we've talked about a few times over the course of the semester, which are those endothelial cells that line our arteries. And so endothelial dysfunction, the dysfunction of those cells, is kind of the first step in the direction towards cardiovascular disease. Yeah. Yeah, there's kind of a little bit of controversy around it, and definitely the kind of the most dangerous type of fat that's fully associated with it would be the trans fats, right? But yeah, definitely high saturated fat diet is still considered a strong risk factor, but there is just a little bit of controversy around it. That's kind of why I put that there. Yeah. I probably put that question mark there a couple of years ago when it was more of a controversy than it is now. But yeah,
Is it like decided?
I mean, it's always been decided that it has, but there is this kind of distinguishing factor between high cholesterol diets, which are different, not always, but it is different than a high saturated fat diet. And so high dietary intake of cholesterol isn't necessarily super tightly linked with blood cholesterol levels, but high saturated fat diets are more closely linked with high blood cholesterol levels. So like, for example, for a long time, like in the late 90s, throughout the 90s, eggs were considered kind of an unhealthy food because they're high in cholesterol, right? But that kind of became clear that they weren't eating a lot of eggs wasn't really associated with raising your blood cholesterol levels. But other things, eating a lot of butter and bacon and stuff like that is associated with it, which has a lot of saturated fat. So that's kind of some of the thing around it. But yeah. Other questions on that? Okay, so yeah, so a little bit more about endothelial dysfunction. Okay, so again, those endothelial cells are the ones that line our arteries. And one of the things they do is they respond to mechanical pressure on them called shear stress. Right, so when our blood's pumped through our arteries, going nice and slow, and then all of a sudden we start exercising, right? It's going to start increasing our cardiac output, and we start getting stress on the walls of our arteries because our heart's pumping harder. That stress pushing out on the walls of our arteries is called shear stress. And when these cells experience shear stress, they release something called nitric oxide. Right? Nitric oxide is a really strong vasodilator, so it causes our blood vessels to dilate. Okay, but nitric oxide is also really important for keeping our blood vessels healthy. Pretty much with high levels of nitric oxide, we keep inflammation down in our blood vessel walls. Okay, so when we start having endothelial dysfunction, we decrease nitric oxide levels, and then that kind of calls in the immune system to our blood vessel walls. Macrophages come in, other leukocytes come in, and start creating inflammation there. Okay, so and it also starts causing some aggregation of platelets on our blood vessel walls too, which will lead to the blood clotting process eventually. And so nitric oxide is made by this enzyme called eNOS, okay? Endothelium-derived nitric oxide synthase. Okay, and the other piece to nitric oxide here and eNOS is that when we have eNOS that isn't doing its job well, it makes a bunch of free radicals instead of making nitric oxide. These are also called reactive oxygen species. And these can damage parts of our cells, but it can also change the look of cholesterol that gets built up in our arteries called LDL. And when we oxidize that LDL, that kind of kicks off the whole inflammatory process. And we'll talk about those steps here in just a sec. So the cause of endothelial dysfunction is when we never put shear stress on our arteries, meaning we don't exercise. Okay. So physical inactivity is highly associated with this, but high blood pressure is also associated with this. So this is kind of how the body works in a lot of ways. It's good when we get like high stress for like a moment and then the stress goes back down, right? But if we have just a little bit of stress for our whole life, then our body doesn't usually adapt well to that, right? And that's pretty much what high blood pressure is versus like going and running for 30 minutes a day, right? And so that high blood pressure damages our endothelial cells. The high cholesterol levels, high blood glucose, visceral fat, inflammation, all of this stuff is associated with damaging our endothelial cells. Okay, and this is kind of just connecting here, showing the kind of all these effects of endothelial dysfunction. Okay, we got platelet aggregation, we got macrophages building up in our artery walls, we got oxidation of the cholesterol that's in our blood, which is LDL, and that leads to plaque formation, leads to the inability to dilate, and eventually progression to atherosclerosis. And then finally, the last step would be a blood clot. Okay, this will kind of, there's a kind of an image on the next slide that walks us through kind of big picture 4 steps in the progression of atherosclerosis. Okay, and again, it all starts with what we were just talking about, which is endothelial dysfunction. Okay, and then that's going to lead to monocytes, which are the cells that turn into macrophages coming into our blood vessel wall. Okay, that's going to lead to our immune system kind of getting activated, and then that calls in a bunch more immune cells to the area. Right, then we start doing all these processes which have to do with inflammation, blood clotting. Smooth muscle cells start making their way up to the blood vessel wall, which is not where they're supposed to be, right? They're supposed to be down in the middle of our blood vessel instead. Eventually, all of this just kind of junk in there turns into the plaque, which would be step 3. And then the 4th step is when the wall of the plaque, the wall of the vessel with the plaque in it breaks, and we get plaque rupture. So when that big plaque breaks, part of what leads to that is it getting its own blood supply. But when that rupture happens, that kicks off the blood clotting process, creates a little blood clot in the artery, and then that blood clot just starts rolling down the artery, right? And the arteries get smaller and smaller and smaller as they go, right? And it eventually gets to one where it doesn't fit through anymore, right? And then it blocks the blood supply there. And so if that happens in your heart, it's a heart attack. If it happens in your brain, that's a stroke. Okay, so take just a second with your team and kind of take these steps here and see if you can kind of match up with what's going on with this image here with these steps. And we'll come back together here in a sec.
It's just like the mind has something. I've already.
Yes.
Yeah.
So, are you just writing to write it next to it? I have a question.
Yeah.
To clarify for myself, for the
Yeah.
type 1 diabetes part, is ketosis the same thing as the metabolic acidosis? Or
Ketosis is one cause of metabolic acidosis. Yeah, you can also have severe diarrhea, and that would cause metabolic acidosis too.
so
Yeah.
it's one of the things that cause
Yeah.
the metabolic acidosis.
Yeah. Mhm.
Okay,
Yeah.
thank you.
You know all this stuff already, Isabel?
Papers.
There you go. I was gonna say. Yeah, exactly. There you go. Yeah. Hmm? Cubs, really? Dang,
PCA just did a little shot.
did he? He's heating up. It's the right time for you guys. Yeah. Thank you.
Also the dysfunction of the enzyme in itself.
Yeah, it's all this stuff too. It's just pretty much when the endothelial cells are not functioning properly then. And yeah. Mhm. Yeah, yeah.
Actually, let us know. So.
It's like low nitric oxide is stimulus for immune cells to go to that place.
Yeah, kind of skipped over that part, but. That's it there. See if it shows it. Show it here.
It's like sometimes knowing why helps.
Totally, yeah, for sure. I don't always have all the details, but yeah, pretty much nitric oxide is an inhibitor of these things called cellular adhesion molecules. So there's VCAM and ICAM, so vascular cellular adhesion molecule, intracellular adhesion molecule. And those are pretty much like the little flags that other endothelial cells stick up when there's like a problem down below. It's like a way to call in the immune system pretty much. And so nitric oxide inhibits the formation of those. And so when we stop releasing nitric oxide, then we get more of those cellular adhesion molecules. And that's kind of what grabs onto the immune cells when they're rolling by and then they come in because of that. So great question. All right. Let's get. Okay. So yeah, this is just kind of a visual way to kind of picture what's going on here. We've got a few different things. We can see step one here, right? This is endothelial dysfunction, really. And what happens with endothelial dysfunction, we have less nitric oxide. That makes leukocytes, white blood cells, start to come into this wall of the blood vessel, right? So this is the where the smooth muscle normally is, right? This is that little thin layer where the endothelial cells are. Right, but this is really where all the plaque is building up in this little layer here. Okay, but the white blood cells start coming in. Okay, step two is now we've got a bunch of white blood cells there, and those macrophages in particular started engulfing all the cholesterol that was built up in our arteries, especially the oxidized stuff. They really like chowing down on that stuff. We also get T cells that come in there. All of that leads to the tissue trying to heal itself, which includes collagen laying down, which includes smooth muscle cells getting kind of brought to that area. The tissue is trying to heal itself from the damage, but all that stuff just ends up becoming a part of the plaque that's there instead. Okay, and then down in 3 here, now we're seeing the smooth muscle cells here, right? They're not supposed to be here, they're supposed to be over here. This is kind of just a messed up version of the vessel trying to heal itself. And then we get some dead tissue in here because macrophages can only eat so much before they die, and then they just kind of die and they get stuck in the wall there. And then kind of get this hard fibrous cap on the artery. And then eventually the end stage is when this plaque breaks. And then that opens it up to the blood passing by. And one of the things that leads to blood clotting is when collagen and other tissue that's supposed to not be in the blood goes into the blood. That causes a blood clot, right? And so that blood clot is formed, and it could just block the artery right there, or it could break off and roll down and then get stuck in a smaller spot to cause a heart attack or stroke. Okay. Questions on that? Okay, and then real quick, just on the connection between these two diseases, one real clear way is that blood glucose itself damages stuff. If we have too much glucose in our blood, it sticks to things, it damages proteins, it damages blood vessel walls, damages our pancreas, damages our liver, all of those things. And it damages eNOS itself, which leads to that endothelial dysfunction and free radical production. And then normally insulin signaling is supposed to actually activate eNOS. So insulin actually activates eNOS in our endothelial cells. But in insulin resistance, that mechanism is broken as well. And so it's just another clear connecting point. And that's pretty much what this shows is the insulin receptor there normally leads to activation of eNOS, which normally leads to nitric oxide, which normally leads to vasodilation. But in someone with type 2 diabetes, it's going to decrease eNOS instead, decrease nitric oxide production, and yeah, go from there. So here's what we're going to do with that little PDF I sent out. It looks like this, okay? What this does is it's every tissue or kind of section from the whole year of this course, okay, last semester and this semester, okay? Just with these two diseases, with type 2 diabetes and cardiovascular disease, I want you to just kind of think about like which part, or yeah, how, with what we just talked about with those two diseases, how did we talk about epithelial tissue? How did we talk about cell membranes, transport, vesicles? How did we talk about proteins and nucleic acids, skeletal muscle, nervous system? Okay, so try to kind of tie together as much as you can because these two diseases hit every single part of the body in this way. So yeah, so take a good, we got a good chunk of time here still. We got about 12 minutes left. So yeah, take some time with your team and just come up with like one thing you see from each disease or at least one of the diseases and kind of plug it into each of these. And then we'll go over it for the last 5 minutes of class. Okay, go ahead.
I was good.
No, real. I just want to remember. Oh, it was just. That's something I'm on my. Sister.
Pituitary. Pituitary is central.
What about
It controls things.
Joel stuff? Yes, it does.
Is the pituitary, does the pituitary have any effect on pancreas?
I mean, it probably does, but nothing we talked about.
It's not locked in. Skeletons.
Making you guys think on the last day here.
I know.
So mean, huh? Yeah.
Do we have to know like this sheet for the exam?
You gotta use your brain right now. That's the thing you should be focusing on. Yeah.
Diabetes, you can get like none.
Diabetic neuropathy. Glucose damages your neurons. Glycosylation.
Insulin induced people with high
Yeah.
levels of insulin. They
High
are
levels of glucose.
resist. Okay.
Probably.
They're
That was what I
resistant
wrote.
to insulin, so would that be like, oh, I'm gonna give myself an insulin injection, but I give myself like way too much? Cause like.
That would be if you had low, that would cause low blood sugar, which does happen in type 1 diabetics.
So
Mhm.
insulin, cause they have low, right? Yeah.
I think, yeah,
Lower all the other blood sugars. So if you have high insulin, like I said, just continue to lower.
if a type 1 diabetic has high insulin, it's because they gave themselves too much insulin, which is common. Right? Yeah, you give too much insulin and then you can get low blood sugar because of that.
Just something about yesterday, there was an image on the TV that came up with like a it's like, this is 10 minutes and this is why I just give and this is 30 minutes. I can think that's just a difference.
Yeah. Insulin's considered a lethal drug in the hospital. Like you give yourself too much insulin and you die. So, yeah. Yeah. So,
Yeah, there's another show I watched, Old School Crime, where a nurse tried to kill a patient by
Yeah.
giving them an insulin.
Yeah. Definitely do it. Yeah.
Yeah, that is.
That's why it took so long to approve the artificial pancreas is because of if your insulin pump messes up, it'll kill you. Yeah. So lots of preventative measures in place. Yeah. Mhm.
Be so regular.
All right, guys, let's come back together. And yeah, we'll just kind of walk through. I wrote them in here. I wrote in a few ideas. It's definitely not everything, but we can just start with our histology section back from BIO 1030, right? Endothelial cells, that was them. You guys don't have to worry about taking pictures. If you want me to send it out, I can. Don't stress out. Okay. Yeah, let's just think about it. Let's use our brains, think about it. Okay. But yeah, endothelial cells, right? This is part of our epithelial tissue. Okay. Our pancreas is part of our glandular epithelial tissue, right? Makes insulin. Okay. That's just one connection there. Cell membranes, vesicles, transport. GLUT4 would be an example of one of those transport proteins. Okay. Insulin receptors are a membrane-bound protein, right? The mechanoreceptors on endothelial cells that send shear stress when we increase our blood pressure, another membrane-bound protein, right? Those are all kind of things we talked about real early on in the class. Proteins and nucleic acids, when we kind of talked about a little bit of organic chemistry in this class. Glucose is one of those organic molecules for sure, but glucose trying to get into our cells so it can be used to make ATP, right? ATP is a nucleic acid, right? And glucose, the reason glucose needs to get in is so our body can break it down and make ATP with it, right? Insulin's a protein, which is why it makes it hard to test for it and why we have to inject it. We can't just swallow an insulin pill because our digestive system would have to break it down into individual amino acids before it could get it into our blood, right? So we have to inject it instead, okay? Skeletal muscle, right? Skeletal muscle wasting is common in diabetes, right? Insulin resistance is a lot to do with the skeletal muscle. 75% of our glucose disposal is done by muscle, right? So in type 2 diabetics, they've got a problem with their muscle for sure. Nervous system, blindness is a common kind of end stage consequence of type 2 diabetes because it leads to glaucoma, leads to damage to the blood vessels that feed our retina, and then our retina gets damaged. Okay, high blood glucose causes Alzheimer's disease. We talked about that. Neuropathy is common in type 2 diabetics, meaning like they have like tingly fingers. Sometimes they eventually have to get their toe amputated and then their foot and then their lower leg because their blood vessels get so damaged that we can't get blood to them, but also they lose feeling in that extremity as well with the peripheral nervous system part. Skeletal system, bone is weakened under low pH conditions for too long. So ketosis can lead to thinning out of our bone because calcium phosphate salts that make up bone aren't designed to function in low pH environments. So it just breaks down the salts of our bone. Endocrine system, early in this semester, right? Pancreas, obviously. Insulin release it declines. Cardiovascular disease is all about that, right? Cardiovascular system, heart attack, atherosclerosis, stroke, all of this, right? The blood, right, was a chunk of this class. So the immune system, right? We talked about macrophages, T cells, cytokines, all these things. That's all a part of this process. A lot of diseases are inflammatory in nature, right? Including type 2 diabetes and cardiovascular disease. So it's interesting that people with cardiovascular disease also typically have gingivitis as well. It's a systemic inflammatory problem that happens in our body. It's not just in the heart, right? Blood clotting, we talked about that, right? That's the end stage of the heart attack or stroke. Respiratory system connected here, right? Because we get increased ventilation because of the ketone bodies, which drops our pH, right? To shed that CO2 when we increase ventilation, right? Digestive system, the liver is a huge part of this, right? Leading to that increased glucose in the blood. And then we have glucose absorption by our small intestine, which increases blood glucose as well. It's all part of this system. And then the urinary system, right? The last one, well, we covered digestive last, but urinary, increased glucose causes kidney failure because our kidneys are responsible for trying to pull that back. And it's just too much stress on the kidneys and damages those kidneys. So all the stuff we talked about all wrapped up in these two diseases, but have a fantastic rest of your day, guys. We'll see you on Friday for the review. All right, bye.